So now, without further ado, it is my pleasure to introduce today's first speaker, Max Ock, a consultant with the Ipsos Healthcare Advisory Team. Max, you have the floor.
Thank you. And hi, everyone, and welcome to this webinar on cybersecurity in the healthcare space. I'm Max Ock, as our presenter said, a member of the Ipsos Advisory Services team, and we're really excited to share and discuss the findings from our recent study. And I'm joined today by two folks that are heavily involved in the hospital security space. That's Joe Scotto, the Chief Marketing Officer for CyberMDX, and David Phillips, who's the North American Business Market Leader for Services and Solutions for Philips. So a quick discussion on the methodology of our study. So this was a double-blinded study that we conducted online, a quantitative survey that took about 20 minutes. We had 130 total respondents. 100 fell into the category of information security respondents, and then the other 30 were biomedical technicians and engineers. And the goal here was to kind of understand the differences in the concerns and practices between those IT and biomed folks across environments and roles. Now, before we get into the data, Joe and David, do you have any comments on the research objectives as a whole? Joe, I can start with you.
Sure. I mean, the objectives were obviously a learning. We were wanting to learn about, the more attitudes and concerns, less about specific data, which is sort of typically what you see in a lot of cybersecurity research. I think the surprising aspect for us was when we looked at the data and started to sort of analyze it, there were a lot of things that seemed a bit disconnected. Without kind of getting into that, we'll cover the details. But as an example, there were things that they were really, really concerned about. Yet in terms of how they were reacting to the concerns and what they were telling us, it didn't seem like it made a lot of sense. So I think overall, to frame it, what we kind of looked at was the learning and then try to create some meaning out of it.
Yeah, I think this is a highly emerging topic, right? Cybersecurity and healthcare, particularly with connected medical devices, is a little different than banking security or hotel security. So when we talk about connected devices or connected medical devices, right, you can think in terms of cloud, you can think in terms of network, you can think in terms of the computing environment in a health system. Then there's this specialized area called medical device where you have a number of vendors with different products out there that have different levels of cybersecurity built into the installed base and different strategies for cyber moving forward. So again, this is a highly emerging field. Some of the differences in attitudes and opinion, I think, reflect the emerging increase in attacks, but also reflect the emerging awareness and thoughtfulness around medical device cybersecurity.
Thanks, guys. And with that, I'll get into a little more information on the types of respondents we had. So if we start on the bottom left, you can see the breakdown of the specific roles. So as I said, the most were, we'll call them IT folks, and that was split roughly evenly between information technology and information security respondents. And then we had, biomedical engineers and biomedical technicians, and all with an average tenure of about 15 years in this field. Then if you look at the top, you'll see their level of influence on purchasing decisions. So if you look at just the top row, looking at the percentage of folks who were primary decision makers for purchasing these products, we can see that for Internet of Things and medical device security, about 60% of them were the primary decision maker, and then 40% were the same for compliance and governance, and then almost 60% for overall IT and or cybersecurity. And one thing you'll notice here is that the percentages along that top row add up to more than 100%, much more than 100% actually. And this indicated to us that these IT and biomed respondents, they're juggling multiple roles as the primary decision maker. They're wearing more than one hat. And then if you take a look at the hospital system size, so mid-size, which we've defined as under 1,000 beds, that made up almost 2/3 of the respondents. And then the large hospitals, or hospital systems, I should say, are over 1,000 beds, and that's about 50 of them. And then lastly, and reflected in the hospital size, you'll see the number of medical devices in the hospital. And you can see it's roughly a bell curve. Most of them are clustered in those middle 2 or 3 buckets from 1,000 to 10,000 and 10,000 to 25. And then we have a few kind of on either end, so either fewer than 1,000 or more than 50,000. So onto the first kind of real data that we got from the study. So this was talking about shutdowns of medical devices. Here we're looking at the split between IT and biomed respondents. And I think a few things to look at here. If you look at the very top row, right, that's forced shutdown of devices by external attacks. And you can see here that the IT folks, they reported these shutdowns as lasting much longer than the biomeds. And if you look, unfortunately, due to small sample size, we couldn't get dollar amounts for all the biomed categories. But if you look at the forced shutdown of devices by external attacks on the right-hand side, you can see that the IT respondents are reporting almost $80,000 per hour as a cost. And so, Joe, there seems to be some sort of disconnect going on here between the IT and biomed folks.
Yeah, I mean, clearly when you look at the external attacks, those numbers there, where you have biomed saying it's about 4 hours, and then you have IT saying it's almost 13, both numbers can't be right. So that's something that sort of illustrates maybe a need to make sure everybody's talking about the same thing, to get everybody aligned, to make sure everybody's using the same set of data points. I think that's kind of one thing that jumped out at me. The other thing, when you look at the right side of this chart, is just the potential bite that device shutdowns take to the bottom line for a hospital. Obviously, we've read about this, and whether the number is $80,000 or $40,000 an hour, or whatever it might be, that's still a sizable number for any 24/7 type of operation, which all hospitals are 24/7. And so if that shutdown is lasting a day, you're looking at $1 million to $2 million in revenue loss. And of course, we've read that some of these shutdowns have lasted days and weeks. So you can see how that really can add up very quickly and really have just a tremendous impact.
And I think about the challenge of protecting these endpoint devices, right? So when we talk about connected medical devices, the definition comes into play. So is a connected medical device a patient monitor or an ultrasound system or an MRI scanner? Is the computing station that I sit at to document my case findings or to document patient care, is that computer a medical device? In some level, even a cell phone that has nurse call capability is actually a medical device. So I think the definition comes into play here as well, that IT may have a broader definition of what is a connected medical device. And I think that plays into the longer time horizon. But Joe, I completely agree with you. Just multiplying 12.8 times $80,000, you're at a little over $1.1 million. So significant cost associated with a forced shutdown, regardless of how you define medical device.
Absolutely.
For sure, and we can take a look at the same data through the lens of hospital size. So just a note here, we asked about these shutdowns on 2 different axes, so to speak. So the first was an external attack versus an attack initiated by an internal action, such as phishing. And the second was whether those shutdowns are forced or proactive. And overall, we saw that forced shutdowns and external shutdowns, those were the ones that contributed to kind of higher numbers, whether that's length of time or money. So here, let's take a look at the third row, right? That's the shutdown to external attacks altogether, proactive or forced. And on the left-hand side, you can see on average, the mid-size hospitals reported about a 10-hour shutdown compared to just 6 for large hospitals. And in terms of the cost, and this is something that surprised me personally initially, it's about $45,000 an hour for the mid-sized hospitals compared to a little less than half that, about $21,000 for the large hospitals. So, Joe, do you think there's something about the different hospital sizes that is leading to this big difference in reported cost and time?
Well, I mean, I think the implication is that the mid-sized hospitals are feeling a lot more pain. And the logical thought about that is they probably have less resources, and it just takes them longer to recover. And so when you look at how much they're saying it's costing them, which is more than double what large hospitals are saying, it's probably because they're resource strained, and it just takes a lot to get the operations back and running. I don't know, David, what are your thoughts?
Our question really comes back, our mid-size and large comes back to health systems as opposed to individual hospitals, I think. And so the question is, for me at least, when I look at a large health system, can they divert patients more effectively to available resources when there is a forced shutdown? So within my own health system,
a good point, yeah.
The biggest cost here might be loss of patient revenue, and that's much more expensive than the cost of remediation, which in and of itself is a huge cost. But I think if I can continue to manage patient care, right, then my cost is going to be lower. If I'm a smaller organization that has to divert patients to other institutions that are not part of my health system, then I'm actually double whammied, right? The cost of remediation plus the loss of patient revenue.
Yeah, makes sense.
Yeah, absolutely, guys. And so now we move to talking about the concern for cybersecurity attacks. A few things to point out here. First, the nature of the question. So this is an Ipsos best practice where we ask respondents to rate something on a scale of 1 to 7. So here that scale from 1 to 7 is how concerned they are. And the percentages you're seeing in front of you are the percent of respondents that picked the top 2 boxes. So 6 or 7 out of 7, meaning most concerned. So on the left-hand side, we went with pre-COVID concern levels. So from the top to bottom, we have the concern that cybersecurity attacks in the healthcare industry before COVID. Then we have what are the respondents' concern about cybersecurity attacks in their hospital before COVID. And then we zero in further, asking about concern for medical devices or IoT as a vector for cybersecurity attacks in your hospital before COVID. And then on the right-hand side, it's the same set of prompts, but just for after COVID-19. And I think the first thing that jumps out to me is that, first of all, the statistics are quite similar, across the board, but they're all kind of 65 to 75%, right? So that's roughly 3/4 of these respondents rated themselves, highly concerned about these types of attacks. And so, Joe, is that consistent with what you've been seeing as well?
It is. It was an encouraging stat to see that everybody gets it. They're well aware of the problem. They're well aware of the impacts of the problem, and that's encouraging to see, because you want to make sure that level of awareness in Cybersecurity Awareness Month exists, and so that was a good statistic to see. The one that I thought was interesting that jumped out to me, first of all, it was great that it didn't change a lot pre-COVID and post-COVID, because they were already very, very concerned, so that's good. But I do note that if you look at the statistics in the pre versus post for medical devices as a vector, there's a pretty significant jump. And I suspect that because of what we had, the situation we had with the pandemic, where medical devices were so critical and shortages of them were rampant, obviously that spilled into that, and you can see that big spike, in the difference.
Yeah, for sure, Joe. And we like to say that WannaCry changed everything. Before WannaCry, of course, information security people knew about ransomware and they knew about vicious malware attacks, but WannaCry really made ransomware a household word. Prior to that, I don't think the use of malware for extortion from hospitals was nearly as rampant as trying to access patient records and so steal patient records in order to get access to credit information. Now you're outright extorting from hospitals and health systems through malware. And so pre-COVID, I'm not surprised by the high levels of concern in the first place. The exacerbation that we see post-COVID really is related to the creativity of the hackers because of the ever increasing volume of attacks that we read about in the news. So keeping track throughout COVID, By March, we had a list of 17 health systems that we knew had an active ransomware attack. That list doubled within a month, and it continues to double over and over again with an exponential increase to today. So just the amount of attacks, the sheer volume is driving that concern for sure. Either way, I think device shutdowns are a concern because of the impact on patient care, or the potential to impact patient care.
Absolutely.
For sure. And so, this is concern about, attacks on the whole, but now let's take a look at, the perception of criticality of an individual attack. So this is asking respondents about, once again, that scale of 1 to 7. We're looking at the top two boxes here, 6 and 7 out of 7, for how critical they think the impact would be if a cyber attack shut down use of a connected medical device. Right, and we can see here, it's not a lot of differences between the different roles and different hospital sizes, but still all in those high 70 or low 80%. So if you look on the left-hand side, the question is, to the respondent, how critical do you think the impact would be? And then on the right-hand side, it's how critical would your C-suite level management think the impact would be? And as you can see, there's a couple percentage point increase going from left to right, but overall, it's just about the same. And Joe, are you happy to see this level of concern about this?
Sure. You can argue why isn't it 100%, but to see that they think their C-suite, 80% of their C-suite recognizes that medical devices just absolutely cannot be shut down, and we need to do everything we can to make sure that is something we prevent. I think that's highly, highly encouraging. And it speaks to everybody's well aware of what's important and well aware of the impact.
And so I think about the previous data that said the amount of time associated with an impact, and obviously it's almost immaterial at this point. The criticality here is, you can speculate and say the criticality here is tied to patient revenue or tied to patient lives and livelihood. It's also tied to clinician satisfaction and clinicians' ability to treat patients with diagnostic tools. So all of the factors, financial, clinical, operational, come to bear when you talk about criticality of device shutdown. The question that I'd ask next, as sort of to lead the witness, Max, is how prepared are we for various kinds of attack?
For sure. And as you guys were saying, you'd think that this level of concern, as we saw on the last slide, and criticality, that would be reflected in spending priorities, so to speak. But as we take a look at this information here, you see that it's not quite the case. So let me first kind of explain what we're seeing here. So this is another scale of 1 to 7 question where we talk about the question is, what is the priority of spending when it comes to budgetary planning? And on one end of the spectrum, cybersecurity is the higher priority, and then on the other end, on the right-hand side, as you look at the screen, other IT spending is higher priority. And considering we were seeing kind of 60, 70, 80% of people being highly concerned about various aspects of cyber attacks, to see here that only 11% were kind of in the top two boxes for cybersecurity being the higher priority, to me was quite surprising. And then that 75% there, that refers to everyone who prioritized other IT spending as a higher priority or as an equal priority to cybersecurity spending. So Joe, what does this tell you about people spending priorities relative to their concern?
Well, I mean, everything's up to interpretation, but this was certainly, in talking about the disconnects, this was one of the most puzzling ones. This really, after seeing the stats about, the extreme concern and everybody saying, that we want to make sure this doesn't happen, to then understand that 75% of their IT budget has a bigger priority was a bit of a head scratcher. And I can tell you that when the report was released, the report that we did on this research, we saw lots of social media posts where people were just really reacting to this. So especially people in the security world. So it really caused a stir. And yeah, I'm a lot of different ways to cut it. One of the potential explanations is there are things that are mandated to spend on because they have an ROI. And cybersecurity, right, obviously doesn't have, I mean, we could talk about value that you get, you're protected, you're lowered your risk, but it's not a return on an investment. And so that typically could play into why spend goes one way or the other. The other thing, and I saw this in the comments, was, well, they just don't have enough dollars. So it could be just a matter of, they have to spend on this and then this is all they have left, which, smacks in the face of what's a priority. But that is what we saw in some of the comments. David, anything, any other things you want to add to that?
And I'm like you, I'm speculating a little bit, but what we didn't ask was, is this the current priority or future priority, right? So folks may have been responding from current versus, hey, we know we need to invest more in cybersecurity spend. It may also be, frankly, related to, I've got to keep my IT operation up and running, right? I've got data centers, I've got maintenance agreements on my software, I've got Microsoft contracts, I have a lot of high priority IT spend. And so those are priorities. Cyber is potentially a second priority today. As these threats emerge, maybe that priority changes in the future. So again, it's a little bit of speculation on my part, but I think it's reasonable to say there could be a time element involved. There also is a necessity of keeping operations running as a priority. So Joe, that's where I would speculate here.
Yeah, fair points. Absolutely. Still puzzling.
Especially given the criticality to the spend, the ratio seems off. And so I don't think, personally, I don't think it's a challenge of ROI. I think an ounce of prevention is worth a pound of cure. And so there is a lot of recognition in the customers that we speak to at Philips that medical device is a vector and that there is protection absolutely required. I think the difference between biomed and IT isn't a difference between them. It is, Joe, back to that point that you've made lots of times around a single source of truth, right? Single source of truth for inventory, for risk assessment, for, what does good look like? And you need a single source of truth for what good looks like in order to have an actionable plan.
Exactly. Everybody's got to be on the same page. Yep.
Absolutely. And that takes us to kind of the next question we asked here, which was really drilling down some specifics in terms of cybersecurity and protection, right? So we asked here about 6 of the most common or well-known existing vulnerabilities that a hospital can protect themselves against or protect their medical devices against. And the percentages you're seeing here are the percentage of respondents that said their hospitals were not protected against these vulnerabilities, right? So if you look at the bottom 2, Apache Struts and Bluekeep, these are fairly well publicized and, a few years back, I should say. And you can see just about half of respondents said their hospitals were protected against them. And then as you go up, first WannaCry, then Ryuk, then MD-Hex, and NotPetya, you can see the percentages increase. And, for NotPetya, for example, 3/4 of the IT respondents and, 3/4 of respondents overall just about were not protected against it. And the last thing I point out is to these ovals at the bottom here. This is the percentage of respondents that said they were not protected against any of these 6 listed vulnerabilities. So Joe, is this surprising to you?
It was. I didn't expect the numbers to be this high. The things, I mean, they're just really well-known vulnerabilities. I mean, NotPetya, WannaCry, even Ryuk last year is huge. One thing I'd mention also is that MD-Hex and MD-Hexray were vulnerabilities in medical devices that CyberMDX actually our research team had discovered. So it was just interesting to see that even in the mix here. But I just think that it's probably a resource issue. I don't know that if they're extremely concerned, again, and it's trying to apply the logic of the data, right? If they're extremely concerned and they're driving whatever they can to combat this, to prevent the attacks and just monitor the threats, it just would seem logical that some of this stuff would have more protection on it.
I think it's complicated too, right? Because there are thousands of devices in an organization. And so in order to protect every single device from the multitude of vendors, you'd have to collect every MDS2 document. You'd have to collect all the vulnerability tables. You'd have to acquire all of the patches where vendors put them out, and then actually apply those to the systems. It is a monumentally large undertaking, right? And it's a pretty manual process if you go about it on a device-by-device basis. Again, from Philips' perspective, as an OEM, we take our obligation to test patches and communicate those to the market very seriously. So within 5 days, we had our WannaCry patches across the board communicated to the market, and we were doing a lot of installed base work with customers across North America, really helping them understand how do I protect each of these individual systems within each modality within a large installed base of other vendors. And so for customers at that time, the data collection burden was incredibly high. And I think you see that reflected here, that there's a resource need to collect all of this content just in order to be prepared for what can I patch, what can I protect. So I think, Joe, the evolution here that I'm seeing is much more network-based systems that have that collection completed to relieve the customer of the burden of collecting all of that content from all of the vendors. Even if the vendors are doing a great job putting out the vulnerability tables, there's still a huge data collection effort. So I think that's where you see the emergence of a lot of strategies that are at a network level as opposed to an individual device level.
Yeah, so probably this question could use a follow-up where we could sort of drill down in terms of, well, what exactly have you done for, to help protect against NotPetya? Because maybe they just were understanding, well, we're never completely protected, right? So it could be just something as simple as that, and then these numbers would make a lot more sense.
Sure. And for the 20% that have no protection for any of the listed vulnerabilities, I mean, that's a little nerve-wracking. hard to believe, because some IS professionals will say, look, what's behind my firewall is my business. My goal is to protect at that level. That's certainly one strategy, but you see a multitude of strategies, again, without a clear definition and standard for what good looks like.
Yep.
Yeah, absolutely, and that's some excellent insight. And I wanted to kind of transition into medical device inventory, right? So this here you'll see two different questions, right? On the left-hand side, we asked them, the respondents, how to best characterize their knowledge of the number of devices in their hospital, right? So you have, if they know the exact number, if they don't know the number, but there's a dashboard of sorts that could tell them, or if they don't have a way to determine that number. And you'll see that about 1 in 7, 1 in 6, and in the bottom here did not have a way to determine that number whatsoever. And I think their policy for device inventory may play a role there, right? So if we're looking at on the right-hand side what the inventory policy is for these respondents within their hospitals for their devices, we can see that the kind of the third and fourth rows, right, mix of automation and manual inventory, and then fully manual inventory, they account for around 60% of respondents, and that definitely surprised me when I saw that almost 2/3 of these respondents still had manual inventory involved in their process. We saw some of them report having 20, 30, 50,000 medical devices in their hospital. So to have a manual component there, it's definitely, I'll say, interesting to say the least. Joe, did you see that the same way?
Definitely. And then coming from the HIMSS conference this year, there was a big focus on productivity, people productivity. So something like this, where you have more than 60% still doing sort of administration type work, and that's kind of my interpretation of this. When you kind of look at manual inventory, I'm thinking they're doing this in spreadsheets when there's lots of different ways to automate this. That to me is interesting, given again another disconnect where we want to make sure everybody's as productive as possible. We're using our resources as efficiently and effectively as possible. And yet there's this big, 60% plus that are still doing things manually. I think the other piece to that is when you look at cybersecurity expertise and how sort of important and critical and precious it is today, in the face of how many shortages there are, that would be problematic. If I've got my cybersecurity expert doing manual work in a spreadsheet to do inventory when I can, when I should be sort of taking his brain and applying it to the things that I really need to, prevent threats and study and analyze. That to me would be, again, another place where, a difference could be made if somebody takes this data, analyzes it in their hospital and within their own teams and, takes some corrective action.
For sure. Most of our customers that we work with at Philips Healthcare have some form of CMMS, some kind of computerized medical device management system, where they are logging devices. In some cases, logging the device comes with software version, may come with hardware version, make and model. Obviously, Philips offers a CMMS as well within our multi-vendor program in particular, where we can catalog things like, does the device have a hard drive? Is the data encrypted at rest? Is it encrypted in motion? You can capture a lot of those cyber details. But in the end, it's you can connect devices, you can collect from a network perspective that inventory on a network basis if you have tooling for that. Otherwise, you are in a totally manual process, but not every device is connected. Remember that a lot of devices are on wheels. They're portable by definition of the device, and things do walk. They walk from one location to another where they're needed, one department to another. And frankly, when equipment gets replaced, sometimes the old one goes in a closet as a hot swap for that rainy day, the time of need situation. So it's very challenging to maintain an accurate device inventory from a network perspective or a manual perspective. So we see that a lot. For Philips, we also see that as we approach multi-vendor situations. In the end, this is a huge manual effort just to collect inventory. Now, on top of that, you're talking about assessing MDS2 content and risk content through vulnerability tables for every single device from every single vendor. Again, from a manual collection standpoint, it's a monumental effort.
Right.
Monumental effort.
I mean, one thing I can just add, a quick add is if the device is connected, you can get 100% inventory. So that's good news there.
Sure.
Absolutely. And we talk about how challenging, how time consuming it can be to manually inventory all these medical devices, and that'll surely have an effect on on staffing needs for these hospitals, which takes us to our next question, which first on the left-hand side just asks for the average number of different types of staff, right? So you have enterprise cybersecurity staff and then medical device and IoT security. One thing that popped up to me was that the mid-size hospitals had just about the same average team size as large hospitals. In fact, slightly more, about half a person more for medical device and IoT security. And then if we look at the middle table here, this is asking about staffing adequacy, right? So we asked respondents, which of the following best describes your enterprise cybersecurity team? Do you need more staff? That's the gray bar on the left. Is the staffing adequate? That's the kind of the colored bar in the middle. And then are you overstaffed? That's these numbers. I'd say I was not shocked to see that most of them do not think they're overstaffed. But I think this, this IT stat here was quite a standout. Given the lack of investment in cybersecurity in lots of these places, to see that 2/3 of IT respondents and about 64% of overall said that they were adequately staffed in that department did surprise me a little bit. But if we shift over farther to the right and look at the team size or the team adequacy for medical device and Internet of Things security, we see that overall the respondents were, say, less pleased with the number of staff, with just about half across the board saying that they need more staff. So, Joe, is this consistent with your experience here?
This was another disconnect. So, again, I'm just looking at the aggregate data, right? So you look at in the healthcare vertical, the ones getting, 80% of the attacks are happening to healthcare providers. When you look at overall breaches, 30% of all sectors are happening to healthcare. So it's getting attacked repeatedly. We know there's a pretty big shortage of cybersecurity expertise across all verticals, and of course, including in healthcare. So it's really hard to hire. And in fact, I saw one statistic that said that it takes about 70% longer to hire a cybersecurity expert versus just someone, a general IT. So when you sort of marry those statistics against the fact that 2/3 are saying, well, no, I got what I need, or I got more than I need, I'm good. It just is another head scratcher to me.
No surprise here to me, actually, Joe. So if I look at staffing adequacy for a medical device and Internet of Things, again, the volume of devices from the volume of vendors, it's not just about collecting the upfront data to assess risk. You need people to get trained and deploy patches across this spectrum of medical devices, most of which require the OEM to validate the patch, or in the case of some devices, you can apply the security patch directly without OEM approval. But again, you have to know per device, what are the regs, what are the capabilities, what are the vulnerabilities identified by the OEM. So I'm not surprised that half of hospitals said, or half of health systems said, we don't have enough resources for medical device and Internet of Things. It is a huge undertaking, and it's a problem that's as an industry, right, as a biomedical device imaging industry, we are all working together to help health systems solve the problem. But I think it's ahead of us, not behind us.
Yeah, I mean, the other possibility here is people may be thinking of this within their own sort of department need. So maybe they requested 2 headcounts to do X, Y, and Z, and so they got 2 headcounts. So they're like, okay, I have what I need. Understood. I think there's that, and then there's sort of like, how are you addressing the whole problem? And those are 2 different things.
Fair enough.
Yeah, absolutely. And this takes us to another aspect of cybersecurity, which is compliance. So here we were trying to suss out the impact of compliance on 2 things, right? On the left, we have the impact of compliance on cybersecurity purchasing. And then on the right, we have the impact of compliance on the job or role of the respondent. And the blue at the top is high impact, right? That's almost always seeking and testing products to ensure compliance, or on the right-hand side, working directly with the compliance team on purchases. And then as you go down, we scale back the impact of compliance, where low impact is, basically not seeing security as a path to compliance, or not interacting with compliance or any compliance requirements. But overall, you can see for the impact on the roles, just about half, or a little under half on average, said that they work directly with the compliance team on purchases. So is this interaction with compliance, was this a surprise to you?
I thought this was great news. It was a surprise, but in a very positive way. I think it's really great to see both the level of awareness of how compliance is something that connects to me and my job role, and then also, like, when I make a purchase decision, I need to just make, do spot checks with certain people and work with the compliance team. I thought that was really great to see this level of awareness.
I just keep in mind what industry we're in, right? I mean,
HIPAA,
We're
right?
talking about target, right? We're talking about healthcare and health systems and health delivery. So compliance is directly tantamount to patient safety. Cybersecurity is directly related to patient safety as well. So the compliance number didn't surprise me, only that it's not higher because it is so critical. I mean, here at Philips, we have a lot of compliance involvement as well. So we are measured by the FDA against our quality processes. All of our employees have to take certain trainings. We have to track that those trainings are taken. So I think whether you're looking at SOX compliance, Sarbanes-Oxley compliance on the financial side, whether you're looking at FDA compliance, whether you're looking at compliance with Medicare and Medicaid requirements, right? You really have to think of this as tantamount to everyone's job because it ties directly back to patient safety.
Great.
Absolutely. And one more aspect of cybersecurity here before we wrap up, and that's cyber insurance. So here we're looking at the split between mid-size and large hospitals. They're fairly similar. More large hospital respondents said they, quote unquote, didn't know if they had cyber insurance or not. You can read into that as much as you want. But I think the overall thing here is about 60% concretely said that they do have cyber insurance, and the rest were split among not having it or used to have it but could no longer get it, maybe after a data breach, or just unable to get cyber insurance. And once again, I got to ask: is this surprising? Are you happy to see this level, or were you hoping for more insured hospitals?
This one I didn't really have an expectation on. I think my takeaway on this one is when it comes to cyber insurance, what's their understanding of it? Because it's good, it's good that this many hospitals are looking to insure against something. It just means that they know this is a real problem. If you didn't think it was a possibility, you wouldn't be insuring your hospital to be protected for it, right? So that's a positive aspect of it. The question I've got is, how do people see it within the organization? And in particular, when you look at like C-suite, are they sort of seeing this as, oh, all right, I'm covered if this happens? And are they walking away with potentially a false sense of security? Because, the level of what you get insured for is going to vary. And in fact, there was a very high profile case recently where a breach, and they calculated total costs at, I think, 113 million. It was like 90 plus million tied to revenue loss, another 20 plus million tied to the recovery costs. So, you're looking at, a huge cost to the hospital, and the insurance coverage covered less than 18 million of the 113 million. So I guess my takeaway out of this is, if they're getting cyber insurance, are they understanding sort of what that means? And if there is, this sort of huge breach, this is what you're up against. So really, you always have to help the insurer. You can't just, even like with compliance, you can't just comply and think you're done, right? Because that's really, they're recommending the bare minimum. And similarly with cyber insurance, you're covered, but you still have to take care of your security. You have to be responsible for it. You have to make sure it doesn't happen. If something does happen, you've got some, coverage here. But that would be my comment on this. I just hope that there's an understanding of what it means.
And Joe, there's a direct linkage between compliance and cyber insurance. So in order to get cyber insurance, there are certain criteria you have to meet. And certainly Windows compliance, firewall compliance, whitelisting compliance are all becoming to the fore of cyber insurance agreements. So the two run hand in hand, I think, very carefully. And to your point, the more you comply with protecting yourself, the less expensive, and the more coverage you get from the cyber insurance, the less you self-protect, the more expensive and less protection you get.
Absolutely. So that wraps up the data presentation part of this webinar. And so before we get to Q&A, I'd like to ask our guest speakers, where do we go from here? What's the kind of next steps for improving or increasing awareness of cybersecurity in hospitals?
Well, David and I have both been sort of echoing the need for the single source of truth. And so that alignment is really critical. And so I think if for any manager reading this data, I think it's always good to go back and spot check that across your teams, in particular your biomedical and your IT teams. Is everybody defining things the same way? Is everybody seeing the problem the same way? Is everybody aligning their KPIs against it the same way? Those things I think are important.
And I think those priorities show also touch clinical departments, right? Because the new whiz-bang clinical tool has to meet those priorities for cybersecurity, right? So making sure those priorities are clear across clinical teams as well, I think, is really important there.
Yep.
And then point 2 here, ensuring resources focus on protecting critical assets. I mean, for years, we've been speaking with CIOs and CISOs about categorization of systems, right? Life critical, mission critical, tier 3, tier 4 systems. So a life critical system obviously is required for patient diagnostic and patient care real time, whether that's a cath lab or a patient monitoring system. If you can prioritize assets based on their clinical requirement, then I think you're a leg up on understanding your medical device profile and ensuring that your connected devices have a clear categorization so you know where to put your investments if you are resource constrained, which frankly we all are.
Absolutely. And then, in aggregate and all the stuff that they're doing, also take a look at what they're doing manually. Now, certainly there are some things that you're going to carve out and say, I really want this done manually because I need somebody's brain focused on X, Y, and Z. But there might be some things that are just administrative tasks that people are putting in an Excel and updating, and that exposes you to manual error, and it also exposes you to using somebody's talents for something that could be put to much better use.
Sure. And that inventory assessment needs to connect your CMMS with your risk posture for all these devices. And I think that single source of truth really comes back to, if I have the right criticality of devices, I know the criticality of cyber, I can link my CMMS, I can link my risk posture. Now I have an actionable paradigm to work in with the resources that I have.
Absolutely. Absolutely. And being able to see it all allows you to protect it. If you can't see it, you can't protect it. I mean, everybody says that over and over again. It's absolutely true. I think the final point is kind of tied to that, which is really to make sure everybody's focused on the holistic problem. And that could have been sort of the difference in terms of the responses from some of the individuals, where they were kind of looking at their department versus, hey, if I had to go solve for this, this is what I would need and this is what I would go do. And I think it's important to be measuring against that versus some sort of siloed target.
Yeah, absolutely. That makes a lot of sense, and it's, even though I've been in this study, it's still interesting to hear a lot of these takes on it. And I'd like to transition over to the Q&A section. We have about 10 minutes left, and we have a few questions here. The first one, which I'll read out now, is do you have insight into C-suite and or IT leadership beliefs about who is responsible for remediation on medical device cyber risks, IT or biomed or hybrid or other? I wonder if some leaders think it is a priority that another group is handling, but that group may not actually be doing so.
I think that's a really loaded question. So as an original equipment manufacturer, the first responsibility is with us, right? We have to design for security. I mean, our initial product design has to cover security. If you choose a Microsoft operating system, there are a lot of inherent features to that Microsoft operating system that expose risk, and there are a lot that protect risk. And so making decisions as an OEM about the initial product design is key, and then keeping up with the Microsoft churn. Microsoft releases patches, security fixes, as well as their monthly cadence of patches. We all look forward to Microsoft Tuesday. So the OEM needs to clearly communicate vulnerability to the marketplace. So who's responsible for actual delivery of that remediation? And again, this comes back to understanding your installed base posture by device and really starting with that electronic inventory and knowing who's accountable for what. So in some cases, you can count on the OEM to upgrade that system, to patch it. And again, that's a service level agreement. If the in-house biomed team has taken responsibility and coordinated that with IT, I think that's really the key. We talked about coordinating across departments, but knowing, hey, we're the biomed team, we're accountable for, I just want to pick something out of a hat. We're accountable for ultrasound service. That means you have to keep abreast of the MDS2 documents and the vulnerability tables coming from the various OEMs. And if you're providing that patch to that level and installing it, if IT says, hey, we have the responsibility and we're going to coordinate with Biomed to execute, or if IT says, hey, we're going to roll these patches out via our central deployment system, typically SMS, whatever, then so be it. Where you can apply central networking systems, you do, and where you have to individually patch, you coordinate that within your organization. So Max, sorry, I took the whole answer there, but I think that's what I see most often, right, is IT and Biomed working together to coordinate a response based on that total inventory in the CMMS.
Yeah, and it needs to be a collaboration, but they own different things, right? Because Biomed owns the management of the medical devices. They don't know security, and then security manages networks, and they know IT networks. They don't typically know how a medical device works, and so it really does need to be a collaboration. But I think the security piece is probably moving more toward the CIO, CISO organization.
Sure. We do see Biomed stepping a lot more into the gray space, which is what I call that security space between Biomed and IT.
Yeah.
And so Biomed's aggressively stepping into that space, and they need to. As a profession, it's critical.
Yeah, absolutely.
Yeah, some of them are physically getting additional certifications and moving into cybersecurity from biomedical, which is going to be great because now you're going to have somebody that really understands both worlds. So the more that happens, the better, for the future.
Really interesting. And I think we had a couple more questions here too. So what would the panel recommend as particular facts and concepts that can be used to secure additional funding for cybersecurity programs? Here, Joe, you want to start with this one?
I mean, I think you have to make the case to your management. There's no shortage of statistics or proof points to just look around and see there actually is a real ROI to this, and it's just to prevent what could be significant losses. The numbers in healthcare are much higher loss-wise from cyber attacks than they are for across all industries. And then certainly some of these high-profile ones, they're exponentially higher than the average in healthcare. There's a lot that is there to go make the case to your senior management team and say, hey, we really need to not just talk about this. We need to be doing stuff, and this is how much this costs. And also understand, if we have these dollars, they have to be prepared to say, this is what we'll get. This will be the result. And I think those pieces all have to come together in order for some of these things to change.
Sure. I think we laid out a pretty straight business case, actually, in the where do we go from here, right? Aligning the impact across departments, ensuring resources are focused on that definition of critical assets, right? Assessing the manual work certainly would be part of your business case. It certainly would be part of my business case, plus the $1 million per attack that we described earlier in this study, right? 12.3 hours times $80,000 an hour. Right, that's another $1 million. And against that, I would say, okay, how do I measure that against the holistic problem? That's where I would start my business case, and I'd be thrilled to stand in front of management or the board of directors and make that pitch that we need additional revenue to prevent this type of exposure and cost exposure.
Absolutely. And that takes me to our last question. The Q&A is still open for attendees if you want to add more in. That is, here, I work for a mid-sized hospital, and I think we do feel strained by resources. Are there any shortcuts you can recommend so we can do more with less?
there are lots of shortcuts, lots of ways to do more with less. For us, we're working on making it really easy for someone to use the solution in the sense that we're going to show the user where to start and then actually guide them with regard to, all right, if I want to mitigate this, give me some options, and we'll be able to actually illustrate the options, show them where their highest criticality risks are, just really kind of point them to the most important things, and then actually spoon feed, this is how you can go do it. So if you don't have something in place like that now, that's a real quick shortcut to make sure you know what you need to protect, and then also have like real guidance on what to do and where your most important things, most urgent criticalities are.
Yeah, very nice. So I think that's the last question we had. I would, Joe and David, I'd open it up to you for any final remarks before I wrap things up. But yeah, if you had anything you wanted to say, please go ahead.
Just if anybody has any questions about the research, feel free to reach out. And it's a pleasure to be here today. Thank you.
Yeah, I really want to echo that and say thank you, Max. Thank you, Joe. It was really fun doing the research study, but also really pouring through the results with you. Thanks to all the attendees and listeners. This is really an emerging area, and we're excited to be part of it. Thank you.
Okay, great. So with that, I'd like to conclude this webinar on perspectives in healthcare security. Thanks to all for attending and for your insightful questions. Thanks to Joe and the CyberMDX team, and David and the Philips team. And thanks to the Ipsos webinar team for putting this together. So, all right, thank you, and goodbye.